right, everybody, welcome back to another episode of the Fearcast. This is the podcast dedicated to OCD and anxiety spectrum disorders, and getting your life back. I'm your host, Kevin Foss, and I'm a licensed therapist specializing in OCD and anxiety disorders. Thank you all so much for joining me. For those of you who are new, so this is a question and answer based podcast. If you have a question about OCD or anxiety, or how to get over it, or how to work with it, or what treatment would look like, or something specific, really specific to something that you're struggling with, or a family member you know is struggling with, you can go to fearcastpodcast.com and you can click on the submit a question link, and you can send that question to me. I will read it, consider it, and likely put it up on a future episode. You can also send me an audio question, which I tend to favor those and put those at the top of the list to be recorded. You can go over to Fearcast Podcast at Instagram. Find me over there, and you can send me a direct message. Click on the microphone in the direct message box, and it'll just record. It records in 1 minute segments, so you can kind of record your question, re-record the next segment, and I'll just edit them all together. But either way, those are the two best ways to ask questions, and I'll put them up on a future episode. For this episode, I had Michelle Massi on to talk about varying levels of care. So sometimes in treatment, you'll hear about something called higher levels of care, or an intensive outpatient program, or a partial hospitalization program, or a residential program. And, you know, they can be really confusing as to what all of that means and how it applies to you. How are you ready for one? Do you need one? Do you not need one? How do you get out of one once you're in one? So I had Michelle on to go over all these questions. So why don't we just jump into that? Let me tell you a little bit about Michelle, and then I'll jump into my interview with her. So Michelle Massi is a licensed marriage and family therapist and has been treating OCD for 15 plus years. Ms. Massi has a private practice in Los Angeles where she specializes in CBT to treat OCD, OC spectrum disorders, and other anxiety disorders in children, teens, and adults. Previously, Ms. Massi was the Associate Clinical Director at the UCLA OCD Intensive Treatment Program. She also worked in the UCLA Childhood OCD, Anxiety, and Tic Disorders Program, as well as the UCLA Adult Anxiety Research Program. Without further ado, here is my interview with Michelle Massi. All right, Michelle Massi, thank you so much for joining us for the Fearcast today. How are you today? I'm
good. It's my pleasure to be here. Thank you for inviting me here.
Absolutely. Well, we have had this conversation to try to get this conversation afloat for a long time. So I'm glad we could finally be impulsive enough to go and do this. So,
yes.
Oh, boy. Well, so you are here today to help talk about different levels of care, higher levels of care. I think a lot of once you start getting into therapy land, you start talking with a potential client, you'll hear things like maybe this person needs a higher level of care, and that can be confusing. You hear terms like residential and intensive outpatient and weekly treatment, or partial hospitalizations. These can all be very, very confusing terms. So I was glad to have you on to talk about what all these terms mean. And also, when would they be called for, and how would one need to or should move between these? So with all that said, go just to answer all the questions.
Great, thank you. So yeah, I totally get this question all the time, and it's so funny because I will also get people who will call me, just sort of like you. I'm sure you've experienced this, where someone will call and say, "I'm looking for a psychologist," and I'm like, "Why a psychologist?" Right? Like they had this idea, I have to have somebody with a PhD,
right?
As opposed to like an MFT or LCSW. I get the same thing with, I need an IOP.
Right.
Where are you getting that language from? Why do you think you need an IOP, or I need an intensive treatment? Tell me more, right?
Right.
I'm sure you get that as well.
Right. And for the noobs out there, IOP is intensive outpatient program, or intensive outpatient or intensive outpatient program. Intensive outpatient.
I usually say outpatient program. I think the P is not part of the outpatient, but is part of the program.
IOPP.
Yeah, right.
Doesn't matter.
What's up with OPP, right?
That's exactly right. I don't know why we're not saying it like that. So anyways, I get that question all the time. People say, my psychiatrist suggests that I need an IOP.
Right. So the way I break it down for people, and we also hear like I need to be hospitalized, or I need, or even we'll have clinicians who aren't so familiar and looking for like, I need a hospitalized program for OCD. So I like to back up and say, like, in the United States, at least, I don't know the numbers across the world, but in the United States, there are only, last I checked, there were 5. There might only be 4 now, but I'll talk about the 3 big ones that I'm familiar with. There's 3 residential major programs, I think 4, maybe 5 residential programs that treat OCD. And what that means is somebody is going to go away. I would say, I know at least 4, maybe 5. I'm going to keep saying that.
Anywhere between 3 and 5.
Right. Anywhere. No, there's definitely 4 because I just remember the 4th one.
Okay.
So it's somewhere between 4 and 5.
Okay.
There are, at least for adults, also kids, there's some as well. But for a residential program, a person is going to go away. I typically say 90 days. Now, they'll be told when they call anywhere from 30 to 90 days, but really expect at least a 90-day program. Some programs will extend beyond that. And you're going to go there and you're going to live there. And it's going to be anywhere from dorm style to like maybe a house kind of style thing, but you're most likely going to share a room with people, and there's going to be 10, 20 people there at a time kind of thing. For kids or adolescents, like Mountain Valley is a great example of one, is more like a school-based program. But it's also a residential, they treat OCD, right? So you're going to go away for that. There are some that take insurance and there are some that are private pay. But when you're thinking about a residential program, what you're thinking of is you or your child can't get out of bed, can't leave the house, can't get to a program, right? I always tell people we want to start with the least invasive treatment plan possible. So we start about thinking about, just outpatient program, which is like somebody coming to see you or me once a week for 50 minutes, right? But if that's not going to work, then we start working our way up. But I'm going to start sort of at the top and go down, even though that's not how I do treatment.
Right. Yeah, I was going to say, because what we're talking about here so far with the residential and the live-in programs, this is the highest level of care that if they I don't want to say graduate to it. Someone would be likely going through some of these lower levels of care,
right? And
this would be a program that would be for the most severe cases.
Correct.
Okay.
And oftentimes what they'll say is like you've basically failed all other treatment, like not modalities, but treatment like arenas, right? Is like you can't do once a week, it's not enough. Once a week outpatient is not enough. And even like an IOP, and I'll get to all of those things. But if you're really severe or your child's really severe, you're going to end up at this residential place. Like I said, it's between typically like 30 and 90 days that you're going to be there. There's individual groups, there are individual programs, group programs, you're living there. And this is even good. I sent clients to residential, even if they're not necessarily as severe, but they're needing to do treatment away from the house for some reason or away from the family for some reason. Because either they're stuck in a rut being around the family or there's family system stuff going on that needs to be broken, right? So sometimes it's not necessarily as severe, but it's that displacement. We need to get out of the house, right? And so that's really good. When we're thinking about residential in an insurance-based idea, right? You have to be willing to be on medication because insurance is unlikely to allow you to be there without medication. Because obviously, if your OCD is that severe, you're going to need medication. And it's also going to want to warrant the fact that you need to be in that program, right? Now, obviously, if you're going to a program that doesn't accept insurance, that's a whole nother ball game. And that's kind of determined by your assessment and whether that program feels like they're the best fit for you. Okay. Step down from that. And a lot of times when somebody goes to a residential program, they will actually step down to a lower level of care before coming to outpatient. Some people will just go directly to outpatient. Some people either within that residential program or be sent to another program will go to a PHP, or a partial hospitalization program, and or an IOP, an intensive outpatient program. And the biggest difference between an IOP and a PHP is just simply the number of hours per day and sometimes the number of days per week, right? So a PHP is typically 5 days a week, and it's kind of like actually insurance terms, because insurance qualifies it as a specific number of hours you're there per day. And I think it's like 5 or 6 at least. Sometimes they are longer, sometimes they're a little bit shorter, but it typically is like a certain number of like groups or sort of credits kind of hours that you're there for the week. Some go on weekends, some go just during the week, etc. Whereas an IOP is anywhere from typically 3 to 5 days a week, and it's typically like 2 to 4 hours a day. So a little bit shorter. There may be some overlap. You may be there 5 days a week. I worked at the UCLA program for 12 years. Ours was a 5-day-a-week program for 4 hours a day, right? Other programs are, where they'll step you down, where you're like only there 3 days a week, or only there like 2 hours for 5 days a week, or something like that. Each program kind of handles it differently. You'll also hear, and there's a lot of the same things where you'll see in IOP, PHP residential. You'll see a lot of the same kind of like, what's the word I want? Like pieces to the program, right? You'll have an individual therapist that you'll meet with. And again, every program's different. UCLA, we saw our individual patients every single day. They were there 5 days a week. Some programs, you'll only see your individual therapist 1 time a week, sometimes twice. Everyone is structured a little bit differently. They will have, whatchamacallit? They will have, what was I thinking about? Groups. They'll have time for exposure. So they all have something kind of similar.
That's very structured.
Yeah, exactly. So you'll have a like different structure depending on where you're going, right? Like UCLA does it different than Rogers does it different than McLean, right? They all have, none of them are more right or more or wrong. It's just kind of how they work it. You will get the same type of treatment across the board from the different programs. Let's see. Then you'll probably, another level of treatment is outpatient programs, right? Or outpatient individual therapy, like going to see you or coming to see me, something like that. And that can also be sort of like, some people will call me and want an intensive program within my practice, right? And all that looks like with me is coming to see me maybe 2 or 3 times a week, or they might see me for a longer chunk of time. Maybe we'll do like, 2 hours per day that we meet. And that's, somebody who wants the flexibility or, can't travel or whatever, or they're just somebody who's already seeing one of us and they just feel like they need a little bit more therapy for a short period of time and don't want to stop treatment with us, and then sort of adjust, kind of go back and forth,
a little bit
right?
more flexible with things.
Exactly.
I generally call that more of an accelerated program. It's not intensive. It's not weekly treatment. It's accelerated.
I love that term. And of course you'll get, there's clinics, that I'm familiar with around here. And I use the term clinic loosely. It's not like a Rogers or UCLA sort of hospital-based clinic, but it's like, colleagues of mine who run sort of a, clinic. They've got multiple therapists that work there, and you might go, they have sort of individualized intensive programs, right? Where you might work with, multiple therapists per day. So it's sort of set up like an IOP, but you might be the only patient doing the IOP at the time, as opposed to where like Rogers or UCLA, it's a program where like everybody's sort of moving through the day at the same time in the same way, doing the same things. And, again, for some people that works. A lot of the IOP and PHP programs have long wait lists, unfortunately, because there are so few of them. Right. So sometimes that works better. Sometimes that works better for kids because, they want to be going after school or in the evenings, that kind of thing. So there's some more flexibility. And then we've got of course, just seeing a therapist once a week for 50 minutes, right? And doing, your sort of weekly exposures and check-ins and things like that.
Mm-hmm. Right. And then maybe even a step down from that, perhaps it's a step down or a lateral step, and we might talk about group therapy.
Right.
And
or an addendum too, right? I have a lot of clients who will do group in addition to, outpatient therapy.
Right. And, and for group, it's, it depends on the group that you're going to be with. There can be some that are a bit more structured than others, some that are just more goals group that are going to be focused on, individually assigned or personally assigned tasks. And, the group encourages them to go out and do their thing, then come back and report back to the group on what is it they did. And they can range anywhere between 4 to 12 people. Who knows how many they can really be.
I mean, I think Grayson, sometimes I've heard from patients that maybe there were like up to 20 people in the room in his goals group.
It's a gaggle of people.
But I don't know. But he offers a free goals group, right? So I think oftentimes when you're doing a more structured thing, I found a good number for a group is anywhere from 6 to 8, because you have enough time, that runs for I would say 90 minutes, because that's, you have enough time for every person to get time to speak, to focus on each person. And it's not too little that it gets this awkward,
quick, go, talk,
back and forth, right? Or, a lot of times people have to miss, whether they're sick or, LA traffic, pre-COVID days, etc. And so, if you only have 4 people in the group and 2 people are out sick, a 2-person group is not as good, in my opinion, as at least having, ideally I said 6 or 8, 4, works as well. But I found dialogue is better. You get more motivation, that kind of thing.
Yeah. I think in my experience running groups, 6 to 8 is kind of the magic number. 8, past 8, too much. 6 is my magic number. If there could be 6 in every group, that would be a perfect thing for me. Anyways, so we've got a whole range of different types of treatment. You're right. It is. It's not treatment modalities. It's kind of treatment structures of the way it can go. Right, all the way up from somewhat and maybe severity is one thing, but also the intensive focus is another thing. Right.
Yeah.
The question that I also get from clients calling and asking about, we offer an IOP as well in kind of a similar sort of fashion that you're talking about from a program that is typically a outpatient, weekly treatment, us doing an intensive versus doing a more clinic-based, hospital-based IOP, PHP, et cetera, is how often is someone going to see their individual therapist? You'll hear people talk about different groups are going to say, or different programs will be more group-based or be more individual-based. Some will have different activities throughout. I just had a client come back from a residential program, not focused specifically on OCD, and they were doing things like art therapy and equine therapy and doing all sorts of other outings, right, that weren't really OCD focused. So, I mean, maybe that's something to tag on as some of these other programs that say they will treat OCD, but aren't some of those 4 or 5 programs that we talk about that specifically do it. But I guess, could you speak a little bit to some of the different structures between more group-focused or more individual-focused, and maybe some pros and cons with those?
Yeah. I'm biased because I think we did it well at UCLA when I was there, where you saw your therapist every single day. I think there was some aspect of that. Now, I'm pretty sure we're the only program that ran like that. I think at least hospital-based program. I think the majority, you see your individual therapist once or twice a week. And I know from the patient perspective, a lot of patients have sort of complained about feeling like they didn't really know what was going on, or they felt sort of untethered because they weren't seeing somebody. But the reality is we have to take our acceptance, our ACT tools in here, and that's just what it is, right? And accept it. And that's the layout of the program, right? You'll still have people who are doing exposures with you. You'll still have exposures you're doing on your own, right? I think there is some benefit to those programs where you're forced to do a lot on your own and you have to self-motivate. And so that's a really big thing to be able to do, because look, the reality is at some point, you're not going to be a patient for life, right? Ideally, I tell my clients a lot of times on the first time I meet them is my job is to teach you so many coping skills and tools and all that stuff that I'm going to put myself out of business. You're going to know I'm sure we all do, right?
I've said my job is to put myself out of a job.
Exactly. You're going to know so many ways of even if your subtype of OCD changes, if you know the basis of exposure and response prevention, right, then you're going to know what to do in that with whatever obsession you're having.
Because OCD is OCD. It's not like it's brand new because it's the new subtype that us in the OCD community have given this arbitrary name to that will inevitably change again. It's all the same stuff. Anyhow, go ahead.
100%. So, so it's one of those things that at some point you're going to discharge, whether you're discharging from residential. I mean, look, if you're discharging from residential, you're going to step down to something, whether it's IOP, PHP, or seeing someone like Kevin and myself in private practice, right? Because you can't go from a, 24/7 program to nothing. That's just not going to work, right?
And I wanted to add on, if I could just jump in on that. It's you will step down, but not because it's protocol. I suppose it is protocol, but it's a good idea after leaving an intense program like that to have individual treatment on a less frequent basis so that you keep having that connection to the process and progress that you've been making.
Well, it's like going from summer vacation or any kind of vacation to going back to school full time or going back to work full time. It's a culture shock, right? It's that all of a sudden, right? So, except we're doing it sort of backwards. It's like being, I used to tell clients at IOP that you're basically taking a part-time job. You're having 20 hours a week. That's how we did at UCLA, 20 hours a week of treatment. And now all of a sudden you have 0 or 50 minutes, right? That's we're chopping that into this, minuscule amount, right? So, and the reality is that we want to make sure we're setting up that support for you when you discharge so that, we know OCD is a chronic disorder. That doesn't mean that it's going to interfere with your day-to-day functioning for the rest of your life, right? But it's back there and it can be triggered at any point. And so when you have the skills, if you're constantly practicing the skills, right, then you're much more likely to kind of be on top of it before it sort of snowballs, should it get triggered.
Yeah, and solidifying those lifestyle changes that you're going to need to make. It's a different perspective on how to approach yourself, your thoughts, the world around you. The intensive or residential program is going to really get you going into that lifestyle change, but you're kind of in this microcosm of thinking in that way there. And then you're just left to your own devices. So when you go back home without consistent connection, you're going to see all the same triggers and the same people and things. And if you just go right back to your old routines, not thinking that you need to have that connection and continued aftercare, you're probably going to fall back into the same old habits and traps.
Yeah, exactly. I want to go back a second because I realized I pointed out why you might end up at residential. I didn't really explain well why you might end up at IOP. Obviously, if you're residential and then you're stepping down, but if you are sort of I have clients I've seen who've been in outpatient with me and we just realized their OCD is severe enough that they need more than just 50 minutes once or twice a week, right? They need a little bit more because what I would always say to my patients is, there's something to be said, clients would come in on Monday after the weekend, right? And I'd be like, how'd you do on your homework? And they'd hold their head low and be like, I didn't do it, right? Because what would happen is Friday would come around and they'd be like, I'm so exhausted from the week. I worked really hard this week. I earned a break, right? And Saturday, you're like, I don't want to ruin my Saturday, or I'm exhausted, or I don't feel like doing it right now, right? And all of a sudden, Sunday night, they'd be like, oh no, I didn't do right. And so Monday they'd come in, sheepishly, right, saying to me, I didn't do it.
Right.
Tuesday morning, right, much more on game for homework because we had just done a bunch of stuff Monday. It was easy to go home and do it knowing they were going to be back on Tuesday, right? So in some instances, having that practice every single day with the accountability, right? Because it's sort of if someone's stuck on something, I may say, okay, I want you to practice this every day at home. And in outpatient therapy, when someone comes in to see me, we may not even get to exposure. And I know, I can't believe I'm saying this live, right? We may not even get to exposure during session because there's so much that happens in a week and only 50 minutes to talk about it, right? But even if we get to exposure in session, then there's a whole week between when I'm going to see them again. And that means that they have to be practicing, right? So IOP might be good if someone's really struggling to practice in between session, or we feel like they need the added practice, right? Because just doing it, they're really struggling to get through it on their own or motivate on their own. But having someone with them, even if, I have a lot of patients who have, compulsions or obsessions around taking medication. And so sometimes going to an IOP might help because then there's somebody they can take the medication with every single day. Now, obviously, I'm going to start in my private practice with trying to have accountability check-ins every single day, either by text or a phone call to say, okay, now's the time to take your medication, or you let me know that you've taken it. But if that's not going to work, right, that might be a good person who would be benefit from IOP so that they can have that practice and get into that routine. And then, come back and step down. So it's, some people might feel like they need that more wraparound program, or they might benefit from having groups and individual therapy, right? They might benefit from being around other individuals who have OCD if they don't have anybody that they know has OCD.
Kind of validation and social accountability.
Right. There are also some programs you talked about, some that don't necessarily treat OCD or maybe treat OCD right? So they may also have equine therapy or some trauma-based therapy, or they might do groups on DBT, which I don't specialize in, right? So they might be getting other skills and tools that I can't offer them in outpatient. So that might be a time somebody would go to an IOP or PHP program. And then in terms of coming from the community and going up as opposed to going from residential down, the difference between IOP and PHP, some programs only run IOP, like UCLA, is only an IOP. Whereas in LA, at least I can only speak for LA clinics because I know them the best.
Yeah.
Rogers, for example, starts as a PHP. So it's just what they determine is how they're going to run their clinic. One is not necessarily better than the other. It's just how they set things up, what they require. And then they'll step people down from a PHP to an IOP, whereas UCLA is just an IOP, right? The other thing you'll see about structure in different programs is length of time that you're going to stay. Right. UCLA was very specific. We had a 6-week program. Patients were there. It's 30 days, Monday through Friday. So it's 6 weeks and you're there 4 hours a day. There's no flexibility to that. Right. Maybe a tiny bit, but really no flexibility to that. Yeah,
that's how it is.
Right. Whereas a lot of other programs, you're sort of there indefinitely, right? Where they'll say usually we'll do about 30 or 60 days, but it sort of depends on how you're doing. And of course, I'm not even discuss insurance and, whether or not they're accepting you to stay for that long, but they may decide that you could benefit for another couple of weeks in treatment, or they may step you down so you're going 2 days a week. And so then it's longer than those 30 days, right? So every program is going to do it a little bit differently. There's not one that's more right than the other. It's sort of what works for you, your family, etc.
Right. And to a certain degree, then that's part of that conversation that the individual, the client, the person who's seeking treatment is going to have with their provider. Again, I think there is a discussion that needs to happen about what you're wanting to get, what is clinically reasonable, and what's clinically called for. Right? A lot of times when I'm working with someone and they're calling and they're saying, I really want an IOP, and they're saying, I really want something that UCLA provides. It's going to be 4 hours a day for 6 weeks and with it. And a lot of, my initial training was in a program that was 5 days a week for 3 weeks, and it was 8 hours a day, individually. I think we know this person. But oftentimes when they say, I need an IOP. What they're often needing is just weekly treatment, because sometimes you'll get a referral from a psychiatrist who doesn't see a lot of OCD, and they're going to say, this is the most severe case of OCD I've ever seen in my life. This person needs an IOP. And what they're sometimes saying is, I don't see a lot of OCD, and this person has OCD. So what they need is a specialist.
Yeah. And I also think, and you probably get this as well too, is that because I've worked in an IOP before, because I've worked with a lot of very severe OCD cases, I sometimes will take on a more severe case that might actually need an IOP in the real world, right? Or if they were with another therapist who hadn't specialized for as long or didn't have as much training or experience, right? Where I'm not necessarily going to shy away from the severity just because it's severe. Right, where I may feel like, okay, I can handle this. Now, of course, I know when it's like, oh, this person, I will tell you, I have a patient who just came back from residential. I have no problem sending patients to residential or IOP if that's what they need. I've had a handful of my clients go, whether it was to UCLA when I was working there, or I've sent people to Rogers in LA here. Right. I've sent people, across the country for residential, whatever is needed. But sometimes I know I will take on a more severe case that somebody else might be like, ooh, that person needs an IOP. And that's just sort of comfort level. I've been doing this for, I hate to date myself, like 19 years. So I feel, a little bit more comfortable taking on some of those cases.
Right. And again, it's because you are a specialist and this is what you do. I think there's that difference between a therapist who you're going to find on psych today who's going to say, yeah, I treat OCD because I took a CBT class in grad school. Right. Whereas, this is all you do, right? Similarly, this is all I do. This is the world that we focus in. Right. I had a quick question to kind of shift back to the differences between some of these different higher level of care programs. So some of them are going to be, again, we talked about more group-based, some of them are going to be more individually based, right? Again, the IOP that I was part of, it was all individual, right? Well, there was one group they met once a week, but it was going to be all individual. Are there, from your perspective, are there any real advantages for the individual who's looking into these programs, a program that's going to be one-on-one based versus group-based? Pros and cons to either one? Yeah.
So it's funny because I don't know that there's really been a ton of research, and I'm not a huge research person, but I don't think there's been a huge amount of research comparing and contrasting. I will tell you, when I was at UCLA, I participated in a research with Dr. Jamie Fusner, where we were offering 20 days of treatment. It was 90 minutes and it was one-on-one. So I was with a patient for 90 minutes, 5 days a week, but 20 days. And the weirdest thing was our patients and they were just as severe as my patients who were coming to IOP at the time. I did both at the same time, right? So I could really see patients doing the exact same treatment. And I don't know how much of it was because of my training, because I was taking what I typically do in 4 hours and doing it with somebody in an hour and a half. The results at the end of treatment, even though it was 10 days shorter and it was all one-on-one, there was no group. Were identical. We were seeing 40 to 60% reduction in symptoms.
Wow.
So, and we would talk about this in our group meetings of I don't get it, right? The person is getting so much less treatment than they are in our typical IOP program. How is that possible? And again, the other clinician, it was just myself and one other clinician who were doing it, right? It was two of us, and we had the knowledge of everything from our groups. And that other person didn't work at the IOP, but they had trained there, so they knew. So we were bringing in all the group information as well as all the psycho ed and the exposure. So I don't know whether it was just because they got one-on-one time or what it was. It just seemed to work, right? So we were seeing the same. Right. I have a colleague who runs an IOP and in their private practice, and it's more of an IOP, but there's no group to it, right? The patient is there 3 days a week for 3 hours, and they see 3 different therapists during those 3 hours that they're there, right? So they switch it up. So it'd be like if you and I and one other person were running an IOP, right? They'd see you for 1 hour, me for 1 hour, and another therapist for 1 hour. No group. and each of us would do exposure with that person.
Yeah.
And it works, right? So I don't know like what the science is behind it. I think it's just sort of, you have to figure out what is going to work for your personality, your schedule, what you're looking for.
Right. And there are a ton of different programs out there that are going to offer different sort of things. Some people really like the structure of it, right? There's the UCLA, having the UCLA name and having to go to the UCLA hospital to go and do this. Some people really going to thrive with that because it feels comforting. It feels whatever.
Right.
Some people really thrive on the, being able to have the flexibility of it. We offer more of a modular one where it's going to kind of, the hours might move around. You might do some weekends, you might do some weekdays, and it's meeting someone where they're at because not everyone can commit to 6 weeks. Not everyone can take 3 months out of their life, right? Yeah. So they're going to have to fit that into their schedule. And so I love that example of that research you were in. So in other words, more is not necessarily more. And there's something huge to the buy-in and the willingness the individual has to treatment. There isn't necessarily anything magical, and I'm probably going to get some emails about this maybe, probably from therapists, but there's not necessarily anything magical necessarily then about doing a IOP with you or with me versus doing an IOP with another program. A lot of it may just be the buy-in and the trust that you're having with that individual and the amount of work the individual going through treatment is going to put into the process. I think I've told a number to every client this rather is, however much work you're willing to put into this outside of the treatment and within the treatment is going to lead to greater results.
100%.
I'm not magical.
No. One of my least favorite questions I get asked by a new client, prospective new client is, like, what's your
success rate?
Like success rate. Thank you. I was like, get better rate. What's your success rate, right? Well, the problem is there's 2 people in the therapy room at least, right? And so no matter how good I am at doing my job, right? Number one, I'm not the therapist for every patient, and I recognize that. But no matter how good I am at doing my job, the patient has to be doing things between session. If you are not doing things between session, whether that's like specific exposures or living life behavioral activation stuff, right? Then you're not going to get the benefit from the treatment. And this is why it's also so important to see an OCD specialist. You had said, like, it doesn't matter who you do a treatment with. I agreed, except it should be with someone who treats OCD, right? Because
I'll agree with that. I don't want to just say just go to anybody.
I knew that's what you meant.
Yeah,
but
thank you for
making sure your listeners don't hear it otherwise. But it's so important that somebody has knowledge in treating OCD. There's definitely different treatment modalities that people do for OCD, but you want to make sure that they're knowledgeable in the OCD treatments so that we can address all the places where you're getting stuck if you're getting stuck in treatment. Right.
And I think that's then where we're going back to the original point about, the various levels of care, right? If someone may not have that motivation to do treatment on a weekly basis, maybe they need a little bit more support and a little bit more hand-holding to go through and have the accountability of a therapist to be there with them, to guide them through that, in order for them to start seeing that this process works and doing exposures, facing your fear works, so that when you do it, you start to see, this is kind of working for me. So that through that process, hopefully they are going to develop more of an internal motivation to do the work on their own. And then hopefully that's where they are going to see some progress and some success in the long run.
Yep. And I say to clients, right, a ball in motion stays in motion. So sometimes what they need is that higher level of care or more frequent session times so that you can just get the ball rolling so that when they're in, once a week outpatient therapy, that they can continue that momentum of treatment, right, and practice, so, yeah.
Well, I know that we're getting to the end of our time today, and I want to release back to the wild here. But is there anything else that you'd want to add to kind of, for someone who's just about to step into this, or they've heard from their, psychiatrist or their, random, I don't know, random therapist. I think
right.
you need
Google
to have
search.
Google search, right.
Right.
If Dr. Google has said that you need an intensive outpatient program, what is one thing that you'd want them to hear or to know as they're starting to embark on this process?
Really think about how the OCD is, and this actually can go for any diagnosis, right? Mm-hmm. How is it interfering in your day-to-day functioning, right? Mm-hmm. Are you pretty functional, but there's a little bit of stuff that's like, it takes you a little bit longer, or you're avoiding a little bit, or is it having an impactful interference in you, right? I tell clients, if they can get to treatment, and it's OCD is impacting them a lot, but they can get themselves to treatment, that start with IOP, right? Mm-hmm. If they can't get themselves to treatment, I had a patient who just couldn't even get out of bed, like literally would go to the bathroom in bed because there were so many compulsions to get out of bed. That's a person who definitely needs residential, right? They're not getting themselves to IOP or PHP on a daily basis. I tell parents, if you need to drag your kid over your shoulder to get to treatment, mm-hmm. then probably an IOP or an outpatient program is not the right place, right? Like they may need somebody else to do that for you. If you are functioning in your day-to-day, fairly well, but you're struggling in one area of life, consider maybe outpatient therapy first and talk with that outpatient therapist. Again, any therapist who specializes in OCD in an outpatient basis will be able to assess, do you need a higher level of care? Do you even need just multiple days a week mm-hmm. of outpatient therapy, right? And they can assess whether that would be a good fit for you or you need something else. So start there.
Right. Awesome.
Yeah.
Well, I'll let you get out of here, but I really appreciate your time and sharing your knowledge about this. If listeners have further questions about this, would you mind jumping back on at some point in the future to go over some of this stuff?
Yeah, happy to. This is my passion, so I'm always happy to talk about it, and I could talk about it for hours on end. So I love it.
Fair enough. Well, awesome. Well, Michelle Massi, thank you so much for joining us.
Thank you for having me.
All right, everyone, thank you so much for making it through that episode. Again, if you have a further question about higher levels of care, feel free to reach out to me at fearcastpodcast.com or fearcastpodcast over at Instagram. And I'll be sure to have Michelle on to answer your question, help answer your question as best we possibly can. So again, if you have a question, feel free to reach out to me either at fearcastpodcast.com or over at Instagram, and I'll be sure to put those questions up on a future episode. So until next time, everybody, please remember that the Fearcast is not a substitute for psychotherapy. If you need a little bit of help in your treatment or need a little bit of direction, you can go over to fearcastpodcast.com, and there's going to be the Find Help link. You can click there, and there'll be some information that might point you in the right direction. So until next time, take a risk, challenge yourself, and don't take your brain too seriously. Bye.